Hello, this is Dr. Jonathan Meyer, Voluntary Clinical Professor of Psychiatry at University of California, San Diego, here to talk about lithium's renal journey in managing the renal adverse effects. How lithium moves through the kidney is something that many people simply don't appreciate. But once you understand it, a lot of the concerns about drug-drug interactions and monitoring become much clearer. Lithium is an ion like sodium, and it gets filtered in the glomerulus freely, and it competes with sodium for reabsorption. Why is that important to know? As many of you may know, that one risk for lithium toxicity has to do with people who experience significant losses of sodium. Typically, it's somebody who either has prolonged vomiting or diarrhea, but every once in a while sweating. It's not just that they lost sodium, but what happens is they replete themselves with free water without electrolytes and then become relatively hyponatremic. This is the problem. It's not just that they lost the sodium, but they don't replace it. They just drink water. And this is why when you start people on lithium, you let them know if they have a GI illness and they need to replete themselves with volume, they should use an electrolyte solution such as Pedialyte. If you have somebody who works outside and it's hot or exercises when it's hot, they need to make sure they get salt. You don't want them to just drink water. Lithium proximally is absorbed through the sodium hydrogen exchanger type 3s on the apical surface, and then it gets kicked out the basement membrane to its cousin NHE1. As we'll talk about a couple of times, lithium is not a good substrate for the sodium potassium pump, and this is one reason why we get problems in certain areas of the kidney. Most of lithium's absorption really happens in the glomerulus, about 60%. Remaining 20% of what lithium is absorbed gets absorbed somewhat in the distal tubules and the ascending thick limb. There we have various transporters, and lithium is absorbed in various places there. But the important and predominant action of lithium really is proximally, and this is the site of the predominant drug-drug interactions, which we'll talk about in another episode. Well, many people, of course, are concerned about lithium's renal adverse effects, and it certainly does have some. What could it do? Well, use of lithium can be associated with declines in GFR, which are more than expected for the person's age, especially when people use multiple daily dosing, which is no longer endorsed, or high maintenance levels, especially any outpatient level above 1.2 or chronic levels above 1, we see more renal dysfunction. The one thing we've come to appreciate is that the people who take lithium have high rates of chronic kidney disease due to independent risk factors such as hypertension, metabolic syndrome, and diabetes. A lot of what we used to blame on lithium is due to the comorbidities, and I'll quantify that for you in a second. Another adverse effect is polyuria. Polyuria is critical to appreciate for a couple of reasons. Patients don't like it, and they'll stop lithium because of it. Also, this is the harbinger of future and more insidious lithium-related problems in the kidney. Recognizing this early and treating it may in fact prevent a lot of the downstream effects we used to blame on lithium. What does lithium not do? Well, although lithium is reabsorbed proximally, it doesn't cause glomerular injury except in rare cases. What is the primary manifestation of glomerular pathology? It's proteinuria. We measure proteinuria these days, not with a dipstick, but with a early morning sample for what's called the albumin to creatinine ratio, or ACR. The most common causes of proteinuria in human beings are hypertension, diabetes, metabolic syndrome. On the other hand, lithium by itself only rarely causes proteinuria. I quote a review here from a few years ago. They found only 36 cases of nephrotic syndrome related to lithium use. It's quite rare. We will talk about getting an ACR to measure urine albumin in patients starting lithium when there is subnormal renal function and also when there's comorbidities. I think the point is to document what's going on so that people don't blame everything on the lithium, because it may relate to the fact that this person has had diabetes for 10 years or poorly controlled hypertension. This, more than anything, as I say, is the keys to the kingdom about understanding how lithium causes its problems. We think that lithium's entry into renal tissue occurs in the collecting duct, where we have a group of cells which are called principal cells. So the way to look at this diagram, as you can see, is the urine stream is on the right, and that's where the apical surface is. On the apical surface of these cells is an epithelial sodium channel, or what we call ENaC. ENac's job is normally to absorb sodium. It just turns out that lithium has higher affinity for ENaC than does sodium, 1.6-fold. The problem is that once lithium gets into these cells, it's not a good substrate for that sodium-potassium pump. It eventually will get out through the sodium hydrogen exchanger type 1, but in some people it builds up significantly, and inside the cell it does all the things that lithium does, but it's now doing it in the wrong place. And this sequelae of lithium's actions in these cells is to cause downregulation of aquaporin channels and vasopressin insensitivity, all of which the patient experiences as polyuria. They'll say, I'm peeing too much, I'm peeing more than usual, and we will be able to measure this as a deficit in urine osmolality. As I say, this is the canary in the coal mine, because we think lithium is getting in via ENaC into these cells, and then eventually gets into other tissues within the kidney and causes all of its problems. The analogy here is that lithium is the uninvited party guest. You didn't ask it to come, but it comes knocking at the door, barges in, pushes aside those nice sodiums. You want to get it out the back door, but you can't get it out via the sodium potassium pump. So what happens is lithium builds up, it trashes your place, and it causes all the problems. But there's a way to treat polyuria, and we're going to hire a bouncer. This bouncer has a specific mechanism of action. It blocks ENaC, and this is going to keep lithium out. One thing we've learned with respect to lithium's renal adverse effects is that how you prescribe it makes a big difference. So the independent effect of lithium we now recognize is not only what we are doing, but it's the people we're giving the medicine to. So this is a look at changes in GFR in adults with mood disorders started on monotherapy with lithium or other agents. We have a couple of atypicals or valproate. These people had mean baseline age around 40, about half female, followed for median values of 2 to 4 years. They all had excellent baseline GFRs, well above 100. Once they adjusted for age, baseline GFR, more importantly, comorbidities, episodes of lithium toxicity or high levels, and the use of interacting medications, they found that the mean annual change in GFR from lithium was around 1 ml per minute, which was not significantly different than 0.4 for comparator drugs. Most importantly, that attributable to lithium alone was 0.24 mLs per minute per year. Yes, lithium can cause an effect, but we realize a lot of it has to do with the comorbidities that are highly prevalent in this population. Lastly, I mentioned before, in this day and age, we no longer give lithium more than once a day because it's associated with more renal insufficiency. This was the best study to prove it. This is a large study done from a US database. They found 1,445 adults who had renal insufficiency, defined as a GFR less than 60, and they matched them 1 to 3 with lithium-treated patients who did not have renal insufficiency. So it's a case control study. They wanted to look at treatment factors that increase the risk for renal insufficiency. Number 1 on the list, once daily dosing was protective. People who received their lithium once a day had 20% lower risk for renal insufficiency. And in this study, the average exposure was not decades. And it shows you that there is no plausible reason to give lithium more than once a day. Not only does multiple daily dosing cause more renal insufficiency, but also we now know that the half-life of lithium in your brain is 28 to 48 hours. People dose lithium 2 or 3 times a day as a historical artifact of practices in the 50s, 60s, and 70s. And sadly, the lithium package insert, which was created in 1970, still says to use it 2 or 3 times a day. We now know this is absolutely incorrect. This is a drug which has a duration of action in your brain of well over 24 hours. There's no reason to do that. And if you give lithium more than once a day, you're causing your patient more renal harm for no efficacy advantage. That same analysis also looked at other factors that might increase risk. One of them, again, was having outpatient levels above 1.2. This increased your risk for renal insufficiency by 72%. They also looked at average levels before the diagnosis of renal insufficiency, and they used as the reference people whose levels were less than 0.60 milliequivalents per liter. We think now the sweet spot for bipolar maintenance is a level between 0.6 and 0.8, and you can see the odds ratio there of 1.42. If you went to the upper end of the range, 0.8 to 1.0, which we'll do for some people, the odds ratio was higher, but if you look at the confidence interval, it really did overlap with those people who are 0.6 to 0.8. I think the important concept here is that you have to use the level which keeps the person stable, but you really want to keep it in that range of 0.6 to 1 and never go above 1.2. If you have somebody who you inherit with a level above 1.2, you want to do everything you can to get it below 1 immediately, and ideally in the range of 0.6 to 0.8. High levels contribute to renal dysfunction. If the person's mania or mood symptoms can't be managed with a level below 1, it's a reason you may have to add a second mood stabilizer or an antipsychotic. But we have to recognize that the old days of excessively high lithium levels on an ongoing basis are simply not acceptable. And this is what's recommended out there in the world now from various guidelines. Acute mania, you can go up to 1.2, but really never above that. If you're having trouble controlling their mania, you may have to add another mood stabilizer, and most of these people are already on an antipsychotic anyhow. For maintenance in people with a history of mania, bipolar 1, schizoaffective bipolar type, 0.6 to 0.8 is the sweet spot. Some people can be treated, in fact, a little bit lower, 0.4 to 0.6, or a bit higher, up to 1, but never above 1. Bipolar 2, not as much literature there. We often say, well, do the same as bipolar 1. Well, let's face it, these people are typically never going to become manic by definition, and so you may consider the lower range of 0.4 to 0.6. And that's also what's used for adjunctive unipolar, just in case you didn't know. Another fact about BID dosing, which is commented on down below. If I have you, for example, on 600 milligrams twice a day, and I say go to the level in the morning, go to the lab in the morning rather than get a level before you take your morning dose, well, it'll be a 12-hour level for your evening dose, but the other half of the dose was taken 24 hours ago. And simply that factor distorts the number you're going to get the next morning. You take that same dose and you mash it all to QHS. You have somebody repeat the level, even though they're getting the same amount of lithium exposure, that 12-hour level will now go up 28%. Why is that important to know? Well, I think many of us were fooled in the past. We had somebody on BID dosing. We said, oh, that level looks pretty good. It's 0.8. Seems fine. Well, if you mashed all of that drug to QHS, that level isn't 0.8, it's probably close to 1.2. It's well above what we would normally recommend and is probably renal toxic. So that's another reason to always have people on once daily dosing at night, because your 12-hour levels will be accurate. If you have people on BID dosing, try to move it all to QHS and then repeat the level and let them know they may actually be overexposed to lithium and will make the appropriate adjustments. If I really have a human being who refuses to go from BID dosing, take that level in the morning and multiply times 1.28, because that's really what their kidneys are seeing, and that'll give you a sense of how high that lithium level might be. Well, what's the appropriate monitoring? I have a drawing here of one of the critical tools, which is the cup. And well, I'll tell you how to use that in a second. You're going to order GFRs. They updated the GFR formula a few years ago to remove the race coefficient, which was problematic in many ways. The modern formula actually uses two analytes, creatinine and cystatin C. And typically, you don't even have to order the cystatin C. The lab will do it. But I would check to see what's going on at your lab. Hopefully they've moved to this more modern formula, which doesn't need to raise coefficient. One of the tools you may not have heard of is called the 24-hour fluid intake record. If you can get patients to do this accurately, it's very helpful. You say, for 24 hours, just write down everything you drink and add up the volume. I sometimes have people do this for a couple of different days and average it. Look, some folks will have trouble doing this, especially those with schizophrenia spectrum disorders. If they can do it, though, it really gives you a sense of how much they're drinking, which is a good proxy for how much they're putting out. When people start to complain that they're peeing too much, in the old days, we do a 24-hour urine collection, but it's just impractical. It's not feasible to do it on a repeated basis. And so now we have a surrogate measure, which is the early morning urine osmolality. If you're having trouble concentrating your urine, the best way to check the osmolality is first thing in the morning. That's where these cups become important. You should have a supply of these cups in your office, and when you go to order the EMUO, first you'll put the order into the lab, but then you'll hand the patient the cup. This way, they can take it home and you instruct them. First thing in the morning, you pee into that cup. And then at your leisure, sometime over the next 5 days, you can drop it off at the lab. EMUO is stable for 5 days at room temperature. They don't have to do it right away. But it's critical, it's the early morning specimen because that's when you are maximally concentrated. Another lab we may order in some people is the ACR, albumin to creatinine ratio. Again, if you have risk factors for proteinuria, if you have subnormal renal function, these are times when we might do this, even before we start the lithium, just to document what's going on so people don't blame everything on the lithium. Coincidentally, the best time to get an ACR is on the early morning specimen. So if the patient's going to do an EMUO, you can get a 2-for-1 there. Again, you have to hand the patient the cup. Don't make them go to the lab to get the cup. It's just an extra trip and they may never make it. And then lastly, talk to your patient. You would think if somebody's peeing a lot, they would tell you, but sometimes people forget. Ask them at every visit, are you peeing more? If they are, you want to get on top of it right away. If people forget, by the time they tell you spontaneously, they may be fed up and ready to stop lithium. As you can see, it's one of the top 3 causes of discontinuation. Ask about it at every visit, because that way you can start doing the appropriate test to figure out the severity of the problem and get people on the appropriate treatment. Here's a summary table of monitoring when you're starting lithium. Again, you don't get an ACR on everybody, but there are certain people for whom you may need to do this. The EMUO, you don't have to do it at baseline, and most human beings, most people concentrate their urine just fine. Sometimes very older individuals don't. Most importantly, a normal value for EMUO is going to be 850 and above, just to give you a sense of what's normal is. As you start to see people who develop nephrogenic diabetes insipidus, you'll see those numbers drop quite significantly. And then we'll monitor people periodically. If you can get them to do the 24-hour fluid intake record, that's great. If they won't, they won't. But if you get somebody to do it reliably, it's a really great proxy for how much they're putting out. Because let's face it, what you drink is going to come out, and they're going to be correlated very, very tightly. Ongoing monitoring will depend really on the extent of the person's renal function and whether there are changes in the renal function. I focus here on the renal function, which is measured with GFR, but look, when you're sending people to the lab, you're probably going to get other non-renal labs such as TSH, the lithium level, and serum calcium. EMUO, you may get periodically, but once you're treating people, and the drug we'll use is a Miloride, you'll get it much more often. And of course, we increase the frequency of monitoring as GFR drops into stage 3A chronic kidney disease, meaning below 60 mLs per minute. If we see significant declines in GFR over 6 months or a year, obviously if we're treating somebody for polyuria, or if in the past we've seen someone transition to abnormal levels of urine albumin, we're going to keep an eye on that. These are typically people who have a comorbidity such as hypertension, prediabetes, or diabetes, which is causing that problem. Well, how do we manage these issues? Well, in the past, if somebody complained that they were peeing too much, we try to get a 24-hour urine collection. But as I said, it's really impractical. It's really problematic to get somebody to do it on an ongoing basis. And so this group in Ireland got 79 outpatients on lithium to do a bunch of things, including a 24-hour urine collection. They also got the early morning urine osmolality and the 24-hour fluid intake record. And they look at the correlations with polyuria. And the clinical definition of polyuria is your urine output more than 3 liters per day. Many people will complain about peeing too much well before they get to 3 liters, but this is the clinical definition. So on the left, we can see that very few people who put out more than 3 liters a day on their fluid intake record were drinking more than 3 liters a day. The problem is, you can see on the right, there are some people with polyuria, seemingly, who are putting out more than 3 liters a day. One person was only drinking 500 cc's. You know that's wrong. It's impossible. But it shows you that some individuals may have trouble doing it accurately. But if you work with people, it's an easy enough thing to do. Just write down what you drink. If you don't know the volumes, use cups, use some measure which we might be able to quantify. On the right is the early morning urine osmolality. You can see everyone with polyuria had an EMUO less than 600. Now, there's other people without polyuria who also had EMUOs less than 600. This points out an important thing, that just because your urine output is 2,900 mLs per 24 hours doesn't mean you don't have a problem. A lot of these people probably did have a problem, but it just did not meet the threshold of polyuria by the strict definition. But this is a reason why, again, you ask people, and if they say, I'm having an issue, you get the EMUO. As it starts to drop, it's clearly abnormal because your EMUO should be 850 or above on millinosms per kilogram. Having an inability to concentrate your urine is not normal, but we know the cause. It's lithium getting into those collecting duct principal cells via ENaC and wrecking havoc. Well, what can we do about it? Well, we are just fortunate. We have this drug, which has been around for decades, called amiloride. Amiloride has a specific mechanism of action. It is an ENaC inhibitor. It is our hero. We have now hired a bouncer to keep lithium from coming in and causing problem because it's going to block lithium from getting in via ENaC. People have done studies showing that even over a period of 6 weeks, we can start to see the effects. But most importantly, you want to treat people as soon as they start to complain. Because what can happen is over time, these principal cells will eventually die off. And then if you finally start somebody on amiloride, they've lost so many of these cells, they may still have trouble concentrating the urine simply because they no longer have the substrate to do the job. Also, people will want to stop taking their lithium if they're peeing too much. So there's a comment here about not combining it with ACE inhibitors, ARBs, or other potassium-sparing diuretics. It's not an absolute. If the person's on one of those agents, you can combine it, and there's actually combo agents out there, even with hydrochlorothiazide, but make sure you monitor the serum potassium. It's really critical. But in many instances, you're starting this early on in treatment because the patient starts complaining, and you see the EMUO dropping. The maximum dose is 10 milligrams twice a day. The standard dosing is 5 milligrams in the morning for 7 days, and you go up to 5 twice a day. You want to give it some time to do its thing. Once you stop lithium getting into these principal cells, it's going to take time for it to be cleared and all of the things it was inhibiting to kind of return to baseline. But our eventual treatment goal is to have an EMUO as close to normal as possible, certainly above 600, and having a 24-hour fluid intake of less than 2.5 liters. Sometimes, though, amiloride is not enough, and these are often people who simply have been neglected for long periods of time. When it's not enough, we have another agent which can be used adjunctively, which is acetazolamide. Acetazolamide is a carbonic anhydrase inhibitor. And there are studies, both in animals as well as humans, and case reports of people using it. It shouldn't be used by itself because it doesn't block ENaC. And the beauty of amiloride is it blocks lithium getting in where it causes problems. So in theory, it's going to reverse the pathology over time. But sometimes people have lost so many of these principal cells, they still have a problem, even if lithium is no longer getting in there. And that's where acetazolamide adjunctively can be very useful. It decreases urinary volume. It should always be adjunctive to amiloride. The interesting fact about acetazolamide, though, is that it lowers lithium levels about 31%. So you will have to adjust the lithium dose, and you'll just have to get a follow-up level. I give you the dosing here, 250 BID. Again, allow it some time, a few weeks to do its thing. You can recheck the EMUO, you can recheck the FIR, but give these agents a few weeks to do their thing and don't be in a hurry to escalate doses. But this combo is perhaps the most powerful tools we have. Be honest, people are so excited about the use of amiloride. There's actually papers wondering, why would we not start people on amiloride when they commence lithium treatment? Maybe we can prevent all of lithium's renal-related problem. Well, we're not yet there as a field. The study needs to be done, but I think it gives you a sense of how important it is to recognize polyuria and get on top of it, because you may in fact prevent some downstream problems from chronic lithium exposure. But sometimes we see GFR going down. Even when you're using it once a day, even when the levels are modest, a lot of it has to do not with the lithium, but the medical comorbidities we see in this population. Number one, you increase the monitoring frequency. I think that's well understood. At some point, though, as you start to get into stage 3B, you're really going to have to talk with the patient about, can we keep you safely on lithium? There's a lot of considerations. This is a nuanced decision. The value in some people is the neuroprotective value because many of these individuals are older. But certainly, if they have poorly managed comorbidities, there's probably nothing you're going to be able to do, which is going to mitigate the decline in renal function. And you may end up having to stop lithium. But you're going to have to start them on another agent first and then slowly take away the lithium. When lithium is stopped over a period of a month, people tend to do better when they have another agent in place than when lithium is stopped abruptly within 2 weeks.